Now I'd like to introduce Steve DuBois from Dana-Farber Boston Children's, and he will provide us an overview of the utilization of radiopharmaceutical MIBG in the treatment of neuroblastoma.
Thank you, Julie, and thank you, Jan, for the opportunity to present at the update course. This is an overview of what I hope to cover over the next 20 minutes or so. I'll give a brief introduction to MIBG, provide some thoughts on patient selection pertinent to MIBG therapy, give some discussion of novel strategies that we and others have investigated for using MIBG at the time of relapse, and then I'll close with where we're moving in with MIBG therapy as a potential component of upfront therapy. And I'll start with something actually not related to MIBG, but really related to high-risk neuroblastoma and the unfortunate reality that these patients present with a tremendous burden of metastatic disease. So this is an analysis conducted while I was here at UCSF and really chronicled the substantial burden of disease that these patients have, with a median of 12 bony metastatic sites at initial presentation. And you can imagine that achieving local control with external beam radiotherapy or surgical approaches would be really impractical. And so that's where I think MIBG may play a particularly useful role in the management of this disease that has a propensity for such widespread dissemination. MIBG is a targeted radionuclide that concentrates in neuroblastoma cells via the norepinephrine transporter. This is an agent that we all use when bound to I-123 for imaging at the time of initial diagnosis and during the course of therapy. But when tagged to I-131 can be a potent form of targeted radiotherapy. This is an agent that's administered intravenously, circulates throughout the body, and is taken up by neuroblastoma cells, where it's then, we think, locked into the tumor cells. The I-131 undergoes beta decay with its half-life of 8 days, and that leads to DNA damage. And if that DNA damage is sufficient, the cell will undergo apoptosis. Because this is a targeted radiopharmaceutical that's administered intravenously, there's really some very important logistical considerations when one is thinking about administering MIBG. And this is really something that I think about as a team sport, really requires a multidisciplinary MIBG team, including oncologists, nuclear medicine physicians and technologists, radiation safety specialists, nurses, social workers, child life specialists, the hospital sedation team. Really, all of these individuals are important to have an MIBG treatment program. And as well, all of the clinical research staff that are needed to fulfill our data reporting obligations and regulatory obligations. In addition, there's physical space considerations that are needed. In particular, almost all centers have a dedicated lead-lined room to administer this therapy, and as well as use of specialized shields to protect caregivers. As well, many centers have parent sleep rooms so that parents can be immediately adjacent to the child, but not in the room, increasing their exposure to radiation. And we've known now for several decades that MIBG, when given as a single agent, appears to be one of the most active agents for patients with relapsed or refractory disease. In terms of the toxicity of this agent, it really appears to be largely hematologic, particularly as the dose increases above 12 millicuries per kilogram. We've learned now that we can use peripheral blood stem cells to support patients through this and really abrogate the degree of hematologic toxicity. Multiple groups in the US and Europe have reported response rates in the range of 20 to 40% with doses above 12 millicuries per kilogram in the relapse setting. The largest study was conducted by Kate Mathey and showed a response rate of 36% with 18 millicuries per kilogram, which is really viewed as the maximum feasible dose of this agent. So I'll turn now to some thoughts on predictors of response and toxicity, and really with an eye towards thinking about patient selection for this treatment modality. We've shown now in two separate analyses that older patients, older than 12 years of age, appear to have a higher response rate to this treatment. And conveniently, older patients are certainly easier to manage in the confines of radiation isolation, and certainly don't require sedation to be managed during their MIBG therapy. There's also important patient disease status considerations. So unfortunately, patients who have rapidly progressive disease going into MIBG don't really seem to benefit from this approach. In addition, one has to be mindful of the parents and nursing staff who need to care for these patients, and we have to be careful about enrolling and treating patients who have significant active comorbidities. So for example, I was referred a patient who had a VIP secreting neuroblastoma and was having liters of diarrhea per day. They were referred for MIBG therapy, and I had to politely decline that patient would not be appropriate given the extensive radioactive diarrhea that would ensue. We also learned that patients who have bone marrow metastatic disease going into MIBG therapy seem to have more hematologic toxicity from this therapy. There's also social considerations that need to be considered. So, for example, pregnant mothers would be a real challenge for a young child receiving this therapy, or certainly children who don't have a caregiver who could help to provide their care while they're in MIBG isolation. We completed an analysis trying to understand, given that the majority of patients in North America who have been treated with MIBG have either had relapse disease or refractory disease, we were interested to know if the response rates were different in those two groups of patients. And overall, we, in this retrospective analysis, we observed a very similar response rate between those two groups, 21 or 29%. But when we looked at the categories of response, we saw that patients who had refractory disease going into MIBG therapy were more likely to have stable disease as their best response, whereas patients who had already had one episode or more of prior progression or relapse were more likely to have progressive disease following MIBG therapy. We also know that we can calculate the whole body dose of radiation a patient receives following MIBG therapy, and we're interested to learn whether that is associated with response or progression-free survival following MIBG therapy. So we had a medical student who was able to analyze all of these data and showed that indeed the dose of MIBG, the radiation dose received by the patient is associated with the administered activity, but not with objective response or with progression-free survival following MIBG therapy. We've also done, in collaboration with the Children's Oncology Group, we've completed two retrospective analyses looking at predictors of MIBG avidity, and have shown that patients who have tumors that have higher levels of norepinephrine transporter or VMAT2 protein expression are more likely to have MIBG avid tumors. And in upcoming work, we hope to now investigate whether patients who have higher levels of protein expression are more likely to benefit from MIBG therapy, which would logically follow, since in theory they're accumulating more of the tracer, but has not yet been tested. And then working with Kevin Campbell, who's here in the front row, we've looked at peripheral blood markers that may inform differential toxicity following MIBG therapy. So this is just one potential marker that we have looked at, plasma FLT3 ligand, as a marker of bone marrow stress following MIBG therapy, and showed that patients who had greater modulation in their plasma FLT3 ligand were more likely to have grade 4 neutropenia following MIBG therapy. So I'll move on now to thinking about some novel approaches that we and others have tried to improve upon the activity of MIBG. And this is really by using MIBG in combination approaches. And really the goal is to try to find a combination that has greater activity by looking for agents that have additive or synergistic activity in combination with MIBG, agents that in and of themselves have some degree of activity against MIBG, and ideally have non-overlapping toxicity with MIBG. So one of the first strategies that we were interested in was to try to find agents that might increase the norepinephrine transporter expression and thereby increase MIBG uptake into the tumor cells and ideally increase the response rate. So we came upon vorinostat, which is a histone deacetylase inhibitor, that has in the laboratory really modest in vitro and in vivo activity against neuroblastoma. But in cancer cells more broadly and in neuroblastoma specifically has been shown to sensitize cancer cells to the effects of radiation, in part by decreasing the expression of DNA damage repair proteins. And then, somewhat serendipitously, we observed as well that vorinostat increases norepinephrine transporter expression in neuroblastoma. So, collaborating with the NANT consortium, we conducted this clinical trial, NANT 0703, that was a phase 1 clinical trial that sought to define the recommended dose of this combination of vorinostat with MIBG. We administered vorinostat for 14 days and administered MIBG once at escalating doses on day 3 of therapy. We enrolled 27 patients and showed that, that we could administer full dose MIBG with a vorinostat dose of 180 milligrams per meter squared and observed a 33% response rate by Curie score. We've also been interested in looking at combinations that may increase the level of DNA damage in the neuroblastoma cells and therefore be more likely to push the cell into apoptosis. And so as part of this, we've been looking at strategies in which we co-administer DNA damaging agents. And a lot of this work was based on preclinical data from the UK looking at the role of camptothecans as a way of sensitizing neuroblastoma cells. So this was work looking, in this case, at topotecan in a neuroblastoma mouse model And compared to vehicle control, you can see that there's activity of topotecan monotherapy, some activity of MIBG monotherapy, but when you administer topotecan concurrent with MIBG, you see very nice tumor regression, really complete responses before the tumor subsequently regrows. In Europe, Mark Gaze has conducted a phase 1 clinical trial of this combination, topotecan with MIBG, and has shown that this is a tolerable approach and forms the basis for an ongoing study called the MATEN study. In North America, we have been interested in the combination of MIBG with vincristine and irinotecan, knowing that these agents have some activity in the disease and that there would be potentially less hematologic toxicity, particularly with a more protracted irinotecan administration schedule. And then as well, our induction regimen in North America already incorporates topotecan, and so we were interested potentially in evaluating an agent that these patients may not have previously seen. So we've now conducted 2 phase 1 clinical trials of MIBG in combination with vincristine and irinotecan. The first study was conducted through the NANT consortium and was called NANT 0406. This study used a 10-day irinotecan schedule, so 5 days of administration during the first week, 2 days of break, and then another 5 days during the second week. And that was really the irinotecan schedule that was most widely used at this time this study was initiated. Unfortunately, that protocol had a fairly high rate of grade 3 diarrhea, which is a known toxicity of irinotecan, and we know that the rates of irinotecan-associated diarrhea increase as you increase the duration of exposure. We did see a nice activity rate with a 25% objective response rate. Given the concerns about that rate of diarrhea, we completed a successor study at UCSF and at CHOP, where we used a 5-day schedule of irinotecan at a higher dose and showed that we were able to reduce the rate of diarrhea to a more manageable level of 8% and showed a very similar objective response rate of 24%. So our current work now is trying to understand whether adding these putative radiosensitizers improves the response rate to MIBG at all. And really, our view is that this question requires a randomized design. And so we're completing now this randomized phase 2 trial through the NANT consortium, where patients with relapsed or refractory disease are enrolled, randomized at study entry to one of 3 treatment arms, Arm A with MIBG monotherapy, Arm B with the combination with vincristine and irinotecan as just described, and Arm C in combination with vorinostat. All patients receive the same dose of MIBG at 18 millicuries per kilo and are evaluated after the first cycle, which is the primary endpoint of the study. We're now at our second interim analysis and hope to potentially have an answer to this question relatively soon, and certainly by ANR 2020. More recently, there's been a great deal of attention looking at MIBG in combination with anti-GD2 therapy, and this really borrows from data in other indications of the abscopal effect in combination either with external beam radiotherapy or other radionuclides. And so there are 2 trials that are now either actively assessing or soon to open to assess the tolerability of MIBG in combination with dinutuximab. So the NANT consortium led by Thomas Cash will be leading the NANT 1701 trial, which is a phase 1 study of MIBG and dinutuximab, and that's expected to open very shortly. And then in Europe, the MiniVan study is evaluating MIBG in combination with nivolumab and dinutuximab beta, and I believe that study is either open or also very soon to open. So we'll look forward to those results to see if that may be another rational combination to pursue in future studies. So I'll turn now in my concluding remarks to MIBG as a component of frontline therapy. And I'll show this, this figure from the same paper from the same industrious radiation oncology resident who really chronicled all of these metastatic sites in patients with high-risk disease, both at the time of initial diagnosis and at the time of first relapse, and really shows that the majority of sites at first relapse were present at initial diagnosis. So the big blue circle here were all of the sites present at initial diagnosis in a cohort of patients with high-risk disease. The smaller circle are the sites of disease at first relapse. And you can see that almost all of the sites present at first relapse were there at initial diagnosis, which really argues to me that local control to these metastatic sites with our current therapy is really inadequate. And because the sites of metastatic disease are so numerous, that a modality like MIBG may be ideally suited to this indication. And really, the Dutch have led the way in evaluating MIBG as a component of frontline therapy. So this is a report of 44 patients with newly diagnosed high-risk disease who were treated with 2 doses of MIBG as their first form of anti-cancer therapy. So patients received a flat dose of 200 millicuries, and then 4 weeks later, 100 to 150 millicuries. And they reported a somewhat astonishing 66% objective response rate that shows that in my view, we think about the response rate in a relapse or refractory setting in the 20s or 30s, and so the idea of using this agent earlier where patients may be even more sensitive is quite appealing. Of course, in North America, we are a larger country than the Netherlands, and there are only a limited number of MIBG centers. And so the Children's Oncology Group, led by Brian Weiss, has completed this pilot study trying to determine is it feasible to administer MIBG therapy to patients with high-risk neuroblastoma, given the distances involved and all of the logistics of moving patients in the midst of therapy. So Brian will be presenting these data later in the meeting, but I'll just leave it to say that indeed he's concluded that it is feasible for patients to travel to MIBG centers, and he was able to identify a tolerable dose to be given preceding a Bumel transplant. And then Ro has already introduced this phase 3 clinical trial that will open truly like tomorrow, very, very soon, any minute, where we hope for the first time in a randomized frontline trial to assess whether adding a block of MIBG therapy may improve event-free survival. So patients with newly diagnosed high-risk disease will be enrolled. They'll receive their first cycle of topotecan and cyclophosphamide, which is our standard induction agent. And their MIBG scan will be centrally reviewed. Patients who have MIBG avid disease will then be randomized to one of 3 arms. Our North American standard, shown here, including tandem transplant. Arm B will be that same standard with a block of MIBG at 15 millicuries per kilo after the 3rd cycle of induction. And then Arm C with a block of MIBG after that same 3rd cycle, but with a Bumel transplant. So as I said, that's going to open very, very soon, and we look forward to sharing those results in about 10 years. So I'd like to thank you for your attention and acknowledge my collaborators, funding sources, trainees, and of course the patients and their families who participate in MIBG therapy. And this was a particularly memorable little girl who came back for her 2nd round of MIBG therapy with a custom T-shirt that says "I glow in the dark." So thank you very much.